Stephen, what do you see as the most pressing unmet needs for patients with molecular alterations, particularly those with rare mutations or some of the more uncommon variants?
You know, we've been very happy in the world of targeted therapy delivering these drugs where we have very high response rates. We have this confidence that when I see an ALK fusion, I give an ALK inhibitor. It's not a setting where I hope this works. It's a setting where I fully expect this to work. It's really a matter of how long, but we have to understand for a lot of these other alterations, our response rates aren't 80%. They're more in that 30, 40%, a lot of room for improvement. So we know if we see MEDX14, BRAF V600E, we're going towards targeted therapy for a lot of these options, but there's a lot of improvement there. So I think the biggest need here is understanding intrinsic resistance and clearly understanding acquired resistance. We're not curing people with targeted therapy. Can we in the future? I hope so. It's not going to be with our current generation of drugs or maybe just one drug. But then I think the big bar, we've seen huge benefits with immunotherapy in terms of long-term survival, maybe even cure. But our patients with drivers have really been excluded from that conversation, which I think breaks all of our hearts. And we really want something that's going to last. It's not something we do now. We don't pursue immunotherapy in this setting because it's not effective. That doesn't mean we don't want it to be effective. It doesn't mean that it won't be effective in the future.
Yeah, I agree. And I think, we also in the past year have seen the approval for a drug for NRG fusions, patients with NRG fusions, including in patients with lung cancer. We know that the overall incidence is very low. Less than 1% of our patients are going to have this particular fusion. But if we see this in a patient, then we have a targeted drug that's now approved. I don't know if any of you have had any experience seeing patients who have NRG fusion.
Yeah, we've done some retrospective work looking at NRG1 fusions, and I've seen several in my practice. One, you have to test to look, and if you're doing DNA testing, you are unlikely to find these when they're there because the gene is huge. It's a massive gene, but it's all intronic, so DNA-based NGS just doesn't have the coverage. You really need to do RNA sequencing, which means that now, as an oncologist, you need to know the details, the metrics of the test that you're ordering. We can't rely on others to do it. We need to know specifically what test is this DNA, RNA, both. And so in RNA sequencing, we can find these alterations. But retrospectively, what we found is these patients do not do well with standard treatment. You see very poor responses to chemotherapy and immunotherapy. Patients that got frontline chemoimmunotherapy, in our cohort, the response rate was 0. In addition, these tumors tend to grow lymphangitically along airways, and so it looks like pneumonitis. It looks like pneumonia. And so patients are getting steroids, they're not getting worse. It's not pneumonitis, it is disease progression, and it's generally symptoms out of proportion to disease radiographic findings. But when we give a targeted drug like zenocutuzumab, the responses can be profound, they can be quick, they can be very durable. So it's a meaningful drug. But again, if we don't find that alteration, we deprive that option for our patients.
Yes, I agree, and I think it's just becoming more and more important as we get more of these targeted therapies approved, more and more important for us to make sure that we are testing each and every patient because the significance is if you find it, even if these rare mutations, it can really alter that patient's treatment course.